So our treatment protocol is when patient comes to see me, the first thing before they see me, they actually get our own Pudendal protocol MRI that is done in our hospital. The same day after the MRI, patient sees my physical therapist, who does a very thorough assessment of patient's pelvic floor muscles and the nerve. I actually see the patient the following day. By then I have the results of the MRI and the assessment by physical therapist. If she has discovered that patient has significant pelvic floor muscle spasm, we schedule this patient for Botox injection. I also give patients vaginal suppositories with Valium and baclofen, which in my practice seem to work best for relieving pelvic floor muscle spasm. Now, when the patient gets Botox, in the ideal situation, if there's no travel issues, arrangements, we want to wait about 2 weeks for the Botox to really start working. If patient does not have a relief of pain with Botox, then the next step is we offer them 3 CT-guided pudendal nerve blocks. They're done by interventional radiologists in my institution. Again, it's a local anesthetic and a steroid. And the goal is to diagnose pudendal neuralgia, and also the goal is to deliver steroid to help with pain.
What degree of pain relief would you say is a positive response? In other words, this patient is highly likely to have pudendal neuralgia.
You mean after the block? So the degree of response that really the patient is satisfied with, meaning if we do the pudendal nerve block and the patient says, it's actually not the degree but the time. So if patient only has a relief of pain of few hours or few days or maybe a week or 2, then that's not good enough. But I do have patients where we have done CT-guided pudendal nerve block and they had 4, 5, 6 months of pain relief. And in those patients, I would not offer them surgery. I would just say, well, come here twice a year and get your pudendal nerve block. So if nothing else has helped, meaning the blocks, the Botox, we proceed with surgical removal of the mesh. And I strongly believe that the entire mesh has to be removed, meaning not only the part that is in the vagina, but also the arms of the mesh that go deep into the body. And that can only be achieved if the surgery is done both vaginally and intra-abdominally. So we do the vaginal, we start with the vaginal part and free up the vaginal part of the mesh.
So you're opening up the vagina,
yes,
with retractors, and
yes,
you're looking there.
And we free up the part of the mesh in the vagina, so it's basically loose but still attached to the arms. And that's the key. That's the only way you can find the arms, if they're attached to that part in the vagina. And then we use the surgical robot, and we make 5 little incisions in the abdomen, and we go in and we find where the arms of the mesh are. So the way it really works, that there is one of my assistants is basically sitting between patient's legs and kind of pulling on the vaginal part of the mesh, and this way we can see where the arms are, and we follow those arms till the end. So
your assistant's tugging on the mesh, and then you see something in the pelvis that is moving, and there you go. There's the mesh.
That's exactly what we do. If patient had mesh placed for incontinence, what I do is, after the mesh is removed, we actually do a procedure that's called a BURCH procedure, which is an old type of anti-incontinence surgery that was almost abandoned with when the meshes came on the market. But once we remove the mesh for incontinence, I want to do this additional procedure to prevent the patient from having urinary leakage. So at this point, when the pain continues, we try in my practice to determine where the nerve compression is. So the next step that we actually do is we do ultrasound-guided selective blocks of the branches of the pudendal nerve. So under the ultrasound guidance, we can block the perineal branch, we can block the clitoral branch. We're not that good blocking the rectal branch. If, based on those selective blocks, which of the blocks gives patients a pain relief, we then proceed with surgical decompression. We do rub the nerve at the end of surgery in this nerve rub to prevent the nerve scarring. And there's several different nerve wraps to prevent it from re-scarring after surgery. We also use activated platelet plasma. So our blood platelets are known to contain growth factors, and it is thought that those growth factors promote growth of Schwann cells, which are the nerve cells which produce myelin, which is again that outside coating of the nerve. So we have been using the activated platelets to again speed up or promote nerve healing. The other thing that we do that is, I think, unique in our surgeon, I think that actually may be one of the most important things, is that we place a Marcaine pain pump right next to the nerve. It drips Marcaine on the nerve for about 2 weeks after surgery. So the idea of doing it is to desensitize the nerve and desensitize the spinal cord. Because I believe that patients that have severe neuropathic pelvic pain, such as those patients, they develop this central sensitization phenomenon in the spinal cord, where which is somewhat like
a programmed pain,
like a phantom pain, programmed pain. So
it's a circle of pain that you're trying to break.
So you breaking that by basically desensitizing the nerve for long enough. So I think by placing that pain pump, I think that is a real game changer. The other thing that we do for those patients is that during surgery, those patients get ketamine infusion. Ketamine is a medication that is known to reverse that central sensitization. And then what we do, if everything else fails, let's say we've done the surgery, we've done mesh, we've done nerve decompression, and patients are still in pain, then we actually admit them to the hospital for a week and we give them a high dose of ketamine infusion, and that seems to be working. I mean, it has to be done after. You can't just give patients ketamine infusion without removing mesh, without fixing the nerve, because that's what actually started the pain. So you need to fix the offending factor, and ketamine is there to reverse that activation of the spinal cord.